This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate. This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Este es el Senado Estatal de California.
This is the California State Senate.
This is the California State Senate.
This is the California State Senate.
Esta es el Senado Estatal de California.
This is the California State Senate.
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 Good morning, everyone. Can you hear me okay? We're going to go ahead and get started. This is the second extraordinary session conference committee on SBX2 number 2 and ABX2 number 1. Informational hearing on managed care organization tax overview. Excuse me. Today is December 1st, 2015. I'm going to make some opening statements, and I'll turn it over to Assemblymember Bonta, see if he'd like to make some opening statements as well. So, again, I'd like to welcome and thank you all for coming again to this first meeting of the conference committee on these two bills introduced in the second extraordinary session to stabilize funding for our Medi-Cal and the DD systems, two programs that are monumentally underfunded, which we can all agree. I want to start by welcoming my co-chair and Assemblymember Bonta and the other conferee present here as well. Today we plan to discuss in more detail the MCO tax structure and the progress that has been made to close the $1 billion gap that was created by the recent federal guidance on this issue. As you know, the MCO tax is the primary mechanism identified by the governor to fill gaps in funding for critical public programs, services laid out in his call for the special session. Our current tax is due to sunset this July of 2016 and is not likely to be reauthorized by the federal government in its current form. In the past meetings of the Senate Public Health and Developmental Service Committee, we have committed to finding a solution to funding the shortfalls identified by the governor. However, since we last met, the Legislative Analyst's Office has projected an $11.5 billion reserve for the 2016-2017, even after assuming the current MCO tax expires. So knowing that, I am a little disappointed that the Department of Finance declined our invitation to be here today, because I believe the recent LAO revenue projection should give us some caution about the impacts associated with the rising cost of insurance. We know a new MCO tax would have an impact on health insurance premiums that individuals, families, and businesses have to pay for a product they are now required to purchase by law. It seems to me that finance should be here to make a case about why the tax remains necessary in light of the LAO projections. Having said that, we must still find ways to appropriately fund essential programs that are struggling to meet our constituents' needs. The DD system has been on the ropes for years, and a recent study by the UC Davis just showed that cancer patients on Medi-Cal do no better than those in California who lack insurance altogether. We can't allow this to continue. We must invest in these programs in order to turn them around, and I am hopeful that this conference committee will serve as a mechanism to do that. And with that, I'd like to turn it over to co-chair Assemblymember Banta and see if he'd like to make any opening remarks, and as well as Assemblymember Santiago, see if he'd like to make some as well. And thank you.
Thank you, Chair Hernandez, and good morning and welcome to the first informational hearing of the Conference Committee on SB2 and AB1 of the second extraordinary session. I first want to thank everyone for being here this morning and acknowledge and thank in advance our speakers from the Legislative Analyst's Office, the Department of Healthcare Services, and the Health Plans. Appreciate your input and your participation today. As most of you know, the legislature is still in special session, and lawmakers have been called on to find ways to increase funding in order to expand access and improve oversight of Medi-Cal and the Developmental Services Program, including the reauthorization of the MCO tax. So today, we're here to listen to our speakers, give us an overview of the Managed Care Organization, or MCO tax, and get an update from both the Governor's administration and the health plans as to where things are in the current status of discussions. The goal of this hearing is to provide the members of this conference committee updated information needed to craft a solution that would assist the state in sustainable funding of the Medi-Cal program and services for the developmentally disabled. I appreciate the ongoing participation of so many stakeholders that are here in this room during this special session, and look forward to a productive session today. Thank you all for being here.
Okay, we're going to go ahead and get started with item number 2, the overview of Managed Care Organization tax. We have Felix Su, Senior Physical and Policy Analyst, Health and Human Services, Legislative Analyst's Office. Welcome, and when you're ready, please proceed.
Thank you, chairs, Mr. Santiago, Felix Su with the Legislative Analyst's Office. I'm very pleased to be here today to provide context and background for issues surrounding the MCO tax. And as is customary, I'll be presenting from a handout that we prepared earlier, which you should all have copies of. So page 1 of the document provides a roadmap for my presentation, which is divided into 3 main parts. So part 1 is just some basic level setting and a refresher or primer as to how we got here. What is the MCO tax? What does it do? And what are some of the current challenges it faces from a federal perspective? Part 2 describes 2 potential approaches to addressing these challenges by restructuring the MCO tax if the legislature chooses to do so. One approach would be the governor's original proposal from his January budget, which would be a tiered tax in the sense that it would tax different health plans at different rates effectively, whereas the other is a so-called flat tax designed to raise the same amount of funding for the state's use, but it would instead be a single uniform tax levied across all health plans that are subject to that tax. Now, these are certainly not the only possible options for crafting a federally viable MCO tax, nor are they the only proposals that have been raised during this special session. For example, we understand that the administration is here today to perhaps provide updates on a recent modified proposal for a tier tax that was introduced in September. However, for the purposes of my presentation, I'll be sticking with these two previous examples because they're familiar to many of you, and we think they're instructive for understanding what are the basic trade-offs in coming up with a viable MCO tax structure. So these are technical and, not surprisingly, complex issues. So we'll try to go at a reasonable pace and keep things pretty high level, which means we'll have to cut corners and at times assert things without a lot of backup or justification. You know, what we like to call the LAO, trust us. But afterwards, hopefully, there will be plenty of time to circle back with any questions that you have about things that weren't so clear at the first go-around. So starting on page 2, what is the MCO tax? The MCO tax is a form of a healthcare-related tax. Well, what's a healthcare-related tax? Essentially, these are arrangements in which states impose taxes on healthcare providers within their jurisdictions and use the proceeds to draw down federal matching funds in their Medicaid programs, often but not always for the purpose of increasing Medicaid payments to those providers who are paying the tax. Now, the federal government has recognized the potential or the tendency of states to use these taxes or fees or assessments in lieu of their general fund resources. So in a purposeful effort to limit the ability of states to construct these taxes, the federal government has come up with 3 interlocking rules that these taxes must meet in order to draw down federal funds. Rule number 1 is that the tax should be broad-based, meaning that it has to be applied to all providers within a certain class, not just those providers that happen to do Medicaid. Secondly, the tax should be uniform, essentially a flat tax applied at a single rate across all providers, regardless of type or size. And lastly, the state cannot provide what is commonly referred to as a hold harmless guarantee. Again, you can raise these taxes to draw down federal Medicaid funds and increase Medicaid payments, but you cannot explicitly provide assurances to any provider that they will at least be paid back what they initially owed in their tax liability. So on page 3, we point out that to some degree, states can seek and receive flexibility in relaxing the first 2 requirements. That is, you can have a tax that is not a purely flat or uniform tax, or one that exempts certain providers and thus is not purely broad-based. However, you cannot waive the 3rd requirement, the no hold harmless guarantee. So to get these waivers, states must demonstrate that, again, 1, they're not providing any hold harmless guarantees to any providers, and 2, the tax has to essentially impose a relative gross burden on non-Medicaid providers that is similar to what would occur under a purely uniform and broad-based tax structure. So the upshot is that you can have a tax that maybe exempts a couple of providers that don't do Medicaid, but you probably can't get away with a tax that exempts all non-Medicaid providers. So that brings us on page 4 to some of the issues facing California's current MCO tax. This is a 4% tax on the revenues that MCOs receive from their Medi-Cal line of business. It, unlike most of our other provider taxes, doesn't actually provide a net benefit to the health plans that are paying the tax. They aren't necessarily worse off because the state builds in the cost of the tax into their plan's Medi-Cal managed care rates. However, instead of using the proceeds to, for instance, fund net increases to Medi-Cal managed care, what the state does is instead use the proceeds to offset other general fund spending in the baseline budget. So what's problematic about this tax is not how we're using the proceeds, it's actually how it's structured. The tax only is imposed on plans that do some Medi-Cal or all Medi-Cal, and it only applies to the Medi-Cal line of business. So as many of you know, while there are many plans that do participate in Medi-Cal, many of these plans also participate in the commercial market, and that business is not taxed under the current structure. The federal government has clarified that it views this type of arrangement as impermissible according to its regulations, and has given states like California a deadline of the end of the legislative sessions. So we're thinking August or September of 2016 to bring their tax structures into compliance. If California doesn't meet this deadline, then it could face being penalized by having to forfeit the federal funds that are leveraged by the current tax, which are on the order of $1.1 billion in the 15-16 budget. So on page 5, to recap, in January, in his budget proposal, the governor offered a new MCO tax structure to replace the current impermissible one. Instead of being a percentage tax on revenue, as is the case for the current tax, the governor proposed a unit tax per enrolled member or life in managed care. This is often referred to as a tiered tax structure because the amount per unit rises and then falls with additional enrollment. At the bottom of page 6, we point out that during this special session, the legislature has considered the idea of another type of enrollment-based unit tax that would be designed to raise the same amount of funding, but again, would instead be a single, flat, uniform rate applied across the board, regardless of enrollment size. So the figure or the chart at the top of page 6 is one that may be familiar to you from some of our past publications, but we've included it because we think it's helpful for visualizing the concept of a tiered tax. Again, this happens to be the governor's January proposal. And to understand the structure of a flat tax, all you would have to do is, instead of having this staircase-shaped configuration, a single horizontal line cutting across whatever that proposed flat rate would be. So on page 7, the key to understanding how these two broad approaches, a flat tax or a tiered tax, really differ is to first recognize what they have in common. And they share quite a lot of features. First, under these proposals, both a tiered and a flat tax, the tax would be broadened to include health plans, not just those that do Medi-Cal, but most health plans that are licensed and regulated by the Department of Managed Healthcare. And what's more, the tax would be assessed on not just Medi-Cal enrollment, but commercial managed care enrollment as well. The point of this is to broaden the tax base to conform with federal requirements. Secondly, according to the administration, the state can continue to build in the costs of the tax for the Medi-Cal portion of enrollment into Medi-Cal managed care rates, and thus make plans whole for at least the Medi-Cal side of their tax liability. And when they do this, they are actually providing a form of Medi-Cal reimbursement that's eligible to receive federal matching funds. This is actually the mechanism by which the state draws down federal funds through this tax vehicle to put towards the state's budgetary uses. Now, thirdly, you cannot do what I just described for commercial tax liability because those taxes on commercial enrollment have nothing to do with Medicaid. Therefore, they're not eligible for federal funds and reimbursement, and you cannot directly reimburse or make health plans whole for the commercial liability without running afoul of the no hold harmless guarantee. So that brings us on page 8 to point number 4. In real economic terms, from a policy perspective, you want to think about either approach, a flat or a tiered approach, as being a direct tax on commercial coverage. And as is often the case with businesses that owe taxes, while the MCOs would legally owe these taxes, over the long term, we think it's likely that consumers and purchasers of commercial health coverage would bear part of the cost through higher premiums. So with all these commonalities, how do these approaches actually differ? It's really a matter of degree amongst these same dimensions. So while both taxes would levy and leverage federal funds, and both would eventually, we think, increase the end cost of commercial coverage, because they're differently structured, how much federal funding you draw down, and who in the industry bears that cost, and how large that overall cost is across the industry really varies as between a tiered or a flat approach. So this has implications, furthermore, as to which tax structure is more stable from a revenue perspective. On page 9, as you're aware, there have been several high-profile mergers taking place in the California managed care industry, many of which do involve plans that participate heavily in Medi-Cal. Now, on top of what's already occurring, if you enact a tiered tax, this could potentially further induce changes in the competitive landscape because you would, at the end of the day, have different plans facing different tax rates and different costs of doing business for the same line of commercial coverage. This could cause some plans to grow and other plans to shrink in terms of overall enrollment. Now, going back to the governor's January proposal, a tiered tax by definition is not uniform and therefore requires a waiver. We think it's possible that down the line, if these enrollment shifts build up enough, the governor's approach could eventually actually no longer be federally permissible, and that could force the state to have to go back and revise and resubmit the tax tiers for federal approval, which could complicate things from both an administrative and budgeting standpoint. Even if the state were to manage to keep the tax tiers permissible on an ongoing basis, the amount of revenue that's raised by these taxes is dependent by design on which plans fall under which tiers. So if you have plans shifting between tiers, you could create a volatile revenue situation under a structure like the governor's approach. Now, in contrast, a flat tax automatically, by definition, satisfies the uniform requirement, so there's no need for a waiver on that front. And furthermore, on page 10, we point out that the flat tax is also immune to this type of revenue jumps or volatility, because it doesn't matter how big or how small each individual plan is, or who merges with whom. At the end of the day, if the total amount of enrollment in DMHC-regulated managed care remains the same across the state, then the total amount of revenue raised by the tax should also stay constant. So far, the flat tax looks to be clearly ahead in terms of revenue stability. But when it comes to the size and the distribution of the financial impact, the picture is more nuanced. So on page 11, we've got an example that we believe is a helpful way to compare these approaches in terms of the tax burden. For the purposes of this presentation, I've chosen $1.36 billion, which is the original amount that the governor proposed in January. That's $1.1 billion for general fund offset and Medi-Cal, which is what the current tax achieves, and an additional $230 million to pay for the IHSS restoration. Now, we're aware that there have been other proposals to raise more revenue and fund other purposes, but for the sake of illustration, please bear with me with this example. So the governor's January proposal in raising this amount, we estimate would create a net liability on the industry across all health plans subject to the tax of about $670 million. And again, when we say net, that's after accounting for the payback that some of the plans can receive for the Medi-Cal portion of their tax. Now, a flat tax to generate that same amount would require a $5.66 uniform rate being assessed on enrollment. And we estimate that the net liability under this approach would jump to $950 million. So it turns out that this example is just a special case of this general phenomenon, which is that if you flatten the tax structure, you end up with the industry as a whole paying out more, and the largest health plans in the state paying out in particular. Now, to drill down on why, take a look at the figure on page 12. This is another familiar one, but we think it's helpful because it shows where Medi-Cal versus non-Medi-Cal plans lie in terms of their overall enrollment size. And it suggests that there's a correlation between being a mid-sized plan and tending to do a lot more Medi-Cal as a share of your overall business. So that's the thrust behind the governor's approach for having tiers. It's to concentrate the highest gross tax burden as possible on plans that tend to do a lot of Medi-Cal, because you can draw down federal funds, you can reimburse the plans for that part of the liability, and you can use those federal funds to achieve your overall funding target. Now, there are exceptions to every rule, as on page 13, and there are definitely some plans in the state that are mid-sized, but they don't do much Medi-Cal or they don't do any Medi-Cal. However, under the requirements of a federally permissible tax, they would have to be subject to the same high tax tiers in the governor's approach. And there would be no recourse through Medi-Cal to make them whole. It's these types of mid-sized, non-Medi-Cal players that stand to lose the most under a tiered approach. So what happens when you try to reduce the tax burden for these mid-sized plans? Well, on page 14, we point out that you end up with a flatter tax. And to understand the implications in terms of tax burden, a helpful analogy might be a hydraulic system in which if you push down one piston, the other goes up. Or if you like, a water balloon, where if you squeeze one end, the other inflates. The point is that if you have a flat tax, by design, it has a lower financial impact on mid-sized plans, but that also means it doesn't raise as much tax revenue from Medi-Cal enrollment because most Medi-Cal lives are in mid-sized plans. Therefore, the amount of federal funds you can draw down is considerably lower. And to make up for that difference, to get to your overall funding goal, you've got to increase the relative tax on commercial coverage. And what's more, the same flat tax that would create a lower average tax rate for mid-sized plans would create a higher average tax rate for the state's largest MCOs. And this table here on page 14 is our back-of-the-envelope estimate as to how these approaches would impact those mid-sized plans that don't do much Medi-Cal versus those largest plans in the state. And the takeaway from these very, very rough numbers is that flattening the tax will mitigate the situation for mid-sized plans, but at a more than offsetting cost for the state's largest health plans, creating a greater overall net liability for the whole industry. So to wrap up, on page 15, this table here summarizes the trade-offs that we just went through. And to be clear, there's no purposeful ranking here in terms of which criteria is more important. It's not as if those that are the most crucial we think are at the top, nor is the sheer count of how many criteria one proposal beats out the other necessarily all that relevant. But we do think this table is helpful to highlight the fundamental trade-offs in designing any type of MCO tax structure. For example, we think it's fair to say that the administration, throughout all its proposals, has consistently emphasized criteria number 3, the total liability on the MCO tax light the fund. For example, throughout all criteria number 3, the total liability as being one of the most important, if not the most, in administration. Furthermore, you may potentially interfere with the competition in the marketplace because you'd be taxing different plans at different rates for essentially necessarily have to give up some in administration. Furthermore, it's not inherently right or wrong for the legislature to have different views on the matter and its own thinking about structuring a proposal. I'll stop there and take any questions.
Thank you very much. Is there any questions from any of the members? Seeing none at this time, I'd like to thank you for your presentation. We'll now move on to item number 3, the Governor's MCO proposal update. Mary Cantwell, Chief Deputy Director, Healthcare Programs, State Medicaid Director, Department of Healthcare Services. Good morning and welcome.
Hi, thank you so much. Mary Cantwell, Department of Healthcare Services. Thanks for having me this morning to talk about where we're at and where we came from in terms of the MCO tax and the final proposal that we released in September that we're hopeful is a viable proposal and one that people will consider carefully as we continue to move forward. As laid out in the background paper, the governor did propose replacement MCO tax in January for all the reasons cited by Mr. Hsu in terms of the expiration of the tax coming this July, as well as the federal guidance that came in 2014 indicating that our existing tax likely did not meet federal requirements and therefore we would be required to change it. A couple key points about how we came up with the original proposal and the guiding principles that we've continued to follow. Really, we had 3 main goals in developing the proposal. One, we wanted to have a replacement tax that would raise the same amount of funding that the existing tax does, and as has been discussed, that's $1.1 billion, plus an additional $250 million that was equivalent to the value of the 7% restoration for IHSS. The second goal was to meet the federal requirements to be approvable and be able to draw down the federal funding. That means, as has been mentioned, that it would need to be broad-based and uniform and not have a hold harmless or otherwise be able to receive a federal waiver of some of those requirements. And then finally, we did really look at how do we limit the financial impact to plans and therefore consumers as we look at now a new tax that has an impact on commercial business. So as has been noted, the January proposal was based on a tiered structure, and really the goal of that was to try to have the tax as much as possible be on Medi-Cal business, because as has been noted, any tax that's collected on Medi-Cal lives, it doesn't have a net financial impact to the plans because we can use federal funds to reimburse the plans for that cost of the tax. So the January proposal resulted in about 65% of the tax being collected on Medi-Cal lives. And it did end up succeeding, we believe, in achieving the 3 goals, as we mentioned, in terms of the required funding, meeting the federal tests, and to a significant degree did limit the financial impact, although it was, still a fairly significant total dollar amount of about $660 million. Since the January proposal, the department and the rest of the administration has been working with the plans, the legislature, and other stakeholders to really consider other potential tax structures to see if there was a way forward, since obviously there was a lot of concern about the January proposal. And so that led us to develop a couple of revised proposals, the most recent of which in our final proposal coming in early September. So just briefly, our September proposal had a few really key changes. It did retain the tiered structure. However, we reduced the number of tiers from 5 to 4, and most significantly, we modified it so that there was actually a set of tiers and therefore a set of tax amounts for Medi-Cal lives that was significantly greater than for non-Medi-Cal lives. And so really a pretty significant differential. And the result of that is that now, in our final proposal, about 85% of the tax is on Medi-Cal lives compared to 65% from the January proposal. In addition, we developed a couple of other changes. First, we did propose to exclude a few plans that are local plans in Sacramento and San Diego, given their unique nature and the key role that they play in the community, as well as we developed tax exemptions for plans that now would be subject to the MCO tax. Given that we would be assessing a new tax, we looked at what other taxes these plans are paying and looked for where we could provide relief. And so therefore we proposed to exempt these plans from both the gross premiums tax as well as the banking corporations tax. These tax exemptions result in about $210 million in tax relief to these plans. With all of these adjustments, we were still able to meet the 3 goals of raising the $1.35 billion for Medi-Cal, meet the federal tests, and we significantly limited the financial impact much further down to just $114 million, so a decrease of more than $500 million from January. At this point, in terms of this tax structure, we don't believe that there are ways to sort of get that number down any lower. We are, I would say on the cutting edge of being creative in terms of being able to meet the federal requirements. However, we're still obviously open to hearing about concerns and understanding what other proposals, either the health plans or others, might have. Certainly, we've heard from the plans over the last year about the concerns that they've had, and we believe our latest proposal really significantly addresses most, if not all, of those concerns. And so, I think I'll close with, we are very concerned about entering 2016 without a replacement tax, given the expiration in June and what the loss of $1.1 billion in Medi-Cal would mean for our program and for our beneficiaries. And so we really look forward to hoping to find a solution so that we can continue to move forward. And I'll take any questions if you have them.
Thank you. Is there any questions from any of the members? Senator Mitchell?
Good morning, everyone. I was just teasing Mr. Chair and told him that I was in hearing room 4203. That's why I'm late. Sacramento people get that. That's our hearing room in the Capitol. Thank you very much. Sure. One quick question. I'm sorry I walked in the middle of your presentation. In reading the LAO report, the background materials provided by the committee for the hearing, what strikes me curious is the lack of alarm that I certainly feel, that I think my colleagues felt, that we talked about certainly leading up to the end of session. We talked about in the couple of hearings where we talked about the MCO tax alternatives that were on the table then. The lack of alarm from the LAO and you in terms of your current projections aren't including an actual tax deal. So should I not be alarmed? Because my sense is,
Sure.
As legislators, we'll be faced with some very difficult decisions if there is no resolution identified. Very tough decisions that I, as Sub-3 chair, will have to face in the Health and Human Services area. So why the lack of alarm?
I'll go first. Certainly, I'm with you on having alarm. It is a significant funding source for Medi-Cal, a stable funding source, not just for this next year, but ongoing. Right. And we are very concerned about the loss of it. And so that's why we have continued to try to work to come up with solutions that hopefully can get people to vote on an MCO tax and get the plans to support this MCO tax, and why we've worked so hard to decrease the impact.
Do you have any comment in terms of?
Certainly, Senator. I'm assuming you're referring, in part at least, to our fiscal outlook, which, yeah, so to basically get to the gist of your question, I think it's been framed as whether there's a need for the MCO tax, but we might, I guess our preferred way of responding to that, reframe it as being a matter of not just need, but what the legislature's wants and choices and priorities are. So if our fiscal outlook is, I don't want to say right or correct because no one's ever right, absolutely, but let's say if it's not too far off. And again, keep in mind that the outlook assumes continued growth in the economy and in revenues, as well as being a current law projection that assumes no new spending commitments in Medi-Cal or in other programs, that the state would close out the coming fiscal year with, by most measures, a very healthy surplus or set of reserves, even assuming the MCO tax expires without replacement. So therefore, it's fair to say that under that scenario, which is one of many possible scenarios, the MCO tax may not be immediately required, in a sense, just from the narrow perspective of keeping the state in the black. But to think and sort of step back for a second, that's not necessarily the sole purpose of provider taxes like MCO taxes, at least from the legislature's point of view. I think it's instructive to recall that the state has long levied these types of Medicaid provider taxes, not just during times of fiscal downturn and deficits, but really as a means of bringing in additional federal dollars to the Medicaid program to support state budgetary spending. And oftentimes that comes in the way of funding Medicaid reimbursement increases to providers that pay the tax that would otherwise be borne by the general fund. The MCO tax is obviously different as a general fund offset, but that doesn't change the fundamental common thread that this is a way to get in federal dollars to support state budgetary spending, in good times and in bad. So what we mean is that you could really take the perspective that these taxes aren't solely meant to plug in a hole when it's raining and there's a deficit in the budget and you have to balance. You may value these taxes on their own, in and of themselves, for the ability to leverage and maximize additional federal dollars for the state's use.
And one more, if I may, Mr. Chair, to not only leverage federal dollars, which is critical for California, but when you say no new spending requirements, I assume you mean no new requirements that the legislature, quite frankly, has already taken action on. For example, SB 243, the raises in Medi-Cal, fee-for-service rates, no further reductions to the AB 97 program, the ongoing painful conversation we have had as a legislature with regard to DDS funding. So when you say no new spending requirements, you're including those critical reinvestments that we have talked about and made commitments to as a legislature.
That's correct, Senator. Okay. Current law projection.
Mm-hmm. Thank you, Mr. Chair.
Thank you. Senator Assemblyman Bonta?
Just a couple quick follow-ups on the points made by my colleague. I think no one is objecting to the positive revenue projections for this year and next year with the surpluses at the end of the year. But my question is, we've had an MCO tax that is a dedicated ongoing source of revenue for our Medi-Cal programs, and is it wise and prudent to substitute that dedicated ongoing source of funding for a 1 year with a 1 year or 2 year surplus revenue, and revenue that we know, because of the cyclical nature of our economy and our state's revenue, will go up and down over time? I mean, so what about tomorrow? What about the next day when we don't have those surpluses? I mean, my view is that ongoing programming should be funded by ongoing revenue. not one-time surplus revenue. And so can you just comment on that?
Yes, Mr. Chair. As everybody appreciates, there's no telling when the next downturn will hit, nor how severe it would be. And if it happens, deficits could soon emerge. There could be other cost pressures that we fully haven't factored into our particular projections, like rising pension costs or spending in other areas. And in all those scenarios, having something like the MCO tax could help moderate the state's ability to stay on sound budgetary footing during those scenarios.
Great, thank you. And some of the surplus, at least the projected surplus for the end of this year, is going to be committed to our Proposition 2 Rainy Day Fund,
That's
right?
correct. We're projecting, again, under current law, a $4.3 billion surplus in the state's traditional reserve account that the legislature has basically full control over.
Okay. Great, thank you. And to Ms. Cantwell, I just want to, I appreciate the overview of the January proposal and then the revisions that were made and the tweaks that helped address some of the challenges presented in that January proposal that emerged in your September proposal. You know, with the new tiered structure, with the exclusions for some of the Sacramento and San Diego plans, with the Medi-Cal Lives tier being greater, do we think it's going to pass federal muster? And we're going to need a waiver for that, right? For the uniformity and broad-based requirements?
Yes, so both our January proposal as well as the September proposal required a waiver from the federal government. What we have looked at in terms of the federal law and in terms of the required tests, we believe that this proposal meets those tests. You know, obviously, until we have a tax to propose to CMS, we won't know for certain, but we have, you know, many experts who we have worked with long and hard on this who really believe from a legal perspective and a regulatory perspective that we are in line with the requirements.
Great. Thank you. And I guess possibly the ultimate question, and maybe there's not an ultimate answer yet, do we have a consensus from the plans on the September proposal? And if not, at this point, how close are we?
I think I'll let the next panelist answer that from the health plans. I wouldn't want to speak for my health plan colleagues.
Okay. Maybe just sort of a more general approach. Is
Sure.
the September proposal getting traction with the plans?
I mean, I think so. I think there was, you know, a lot of appreciation and interest in the changes that we were able to make and really trying to be creative. And a lot of that, you know, really was spurred on by our conversations. And so I certainly believe there's an appreciation and understanding for what we've done. And so, you know, again, we, you know, as the secretary said in September when we weren't able to get this done then, you know, we really are looking to our colleagues at the plans and others to really take this on and tell us what else is there possibly that we could do. Because we do think this is as far pretty much as we can get. And so certainly be looking forward to hearing from our health plan colleagues next.
Great. And just final question, there's been some reference to sort of cost pressures in the Medi-Cal program. Can you specify what some of those are, sort of overall growth in the program, rising cost of healthcare, what else would it be?
Sure. I mean, I think as everyone probably in this room is well aware, the Medi-Cal program continues to grow at a very substantial rate, which is great. We are very happy that we're able to provide health care to getting close to 13 million Californians now. Obviously, with that comes, you know, cost. And so we have that. We have, you know, just rising health care costs. Generally, we have new federal requirements, new benefits that we're having to add, as well as, you know, changes that are coming with our waiver renewal. All of those things, you know, just add to the potential pressures on the Medi-Cal program. And so that's why we view this as one of the very critical elements to make sure that we do have this stable ongoing funding, as I said, not just for this next year, but for the next, you know, several years and ongoing, because, you know, I'm certain we're going to get close to cracking that $100 billion budget for the Medi-Cal program and continue to grow. And we want to make sure that we have the funding to be able to provide quality services to our beneficiaries.
Thank you to both of you.
Point he made. Thank you. Just as a follow-up, in addition to reviewing to the best of your ability whether or not it will meet federal requirements, I think I may have asked this question at the August or September hearing, but I don't recall your response, or if you've done some work since then. Have we looked at other state models to get some,
Sure.
perhaps, guidance?
We have spoken to other states who are struggling with the exact same issues. No one has come up with a different solution, a better solution. The other states who are having to replace them also have not actually enacted replacement taxes. So we're all struggling with the same issues of, the impact to the commercial market and how do we deal with that. So at this point, we continue to talk to each other as Medicaid programs to share ideas, but at this point, no one has come up with anything different from the ideas that have been discussed here.
And then when the plans present, I'll ask the same question, if there's a National Plans Association, if you guys are having those same kind of conversations or not. Thank you. Thank you, sir.
Thank you. I'd like to just kind of follow up on what Senator Mitchell said with regard to the LAO's projection and the $11.5 billion reserve, but more importantly, the MCO. And for me, the reason why I think it's very important that we continue to move forward with this. Obviously, my biggest concern is if that $11.5 billion reserve, a good majority of it's going to go to K through 12. Some of it's going to go to the rainy day fund, and there's, what's the estimate? What, $3.5–4 billion? $4.3 billion. How much?
Oh, our projection is $4.3 billion.
So there's $4.3 billion.
Traditional reserve
So
account, yeah.
let's say we don't have an MCO tax for whatever reason. Let's say the feds don't approve it. We can't come to an understanding with the plans. Then we have to now backfill some money that we were getting, some federal offsets, and that's going to be that much less money for other services that are going to be available for the legislature to determine where that money is going to go to. So I still believe that the MCO is a very important part of the puzzle for a couple of reasons, as you were mentioning as well, Mr. Sue, is that we are drawing down federal dollars. By bringing in those federal dollars, that's not state general fund money that we can bring into the coffer to help with to offset the cost for Medi-Cal. But more importantly, as you mentioned, the fact that we have good times now, but in bad times, that's still money that's going to be coming in. Saying that, I do have some concerns with the way the MCO tax is structured, and I'm going to eventually get to a question to Ms. Cantwell. And first of all, I'd like to thank you for all the work you've done. I know you and I and Director Kent obviously have been in collaboration working with trying to figure out how we're going to come to some kind of resolution with the plans where it's sort of your modified tiered section. But the question I have for you is, with the MCO, with the modified tier, and even with the tax exemptions, the gross premium, the bank corp, what will be the impact that is going to go on to the insurance premium payers that are non-Medi-Cal? Do we have any kind of estimate what that might be? Because that's one of my concerns.
So, obviously it's not my area of expertise on how plans pass on tax costs, but as we've talked about in prior hearings, it's certainly wouldn't be surprising to see that happen. In the aggregate, I think about, the original January proposal was about 0.5% of revenue. Now it's down to under 0.1% of all revenue. Obviously that differs among plans, but if I'm recalling correctly, and I can certainly follow up, I don't think any plan is seeing an impact of sort of more than 1 or 2%, and even that's very rare, and most are significantly below that. So we're talking about a very different result than January, where, admittedly we had some plans, and I think this is what led us to really look for significant changes, who were in, the 3–4% impact, which not only would have an impact on consumers, but also, as was noted, could have some market issues, right, and sort of choice impacts on consumers. And so certainly there will be an impact. We've brought it down to as small as we think it can be. But we're not going to get to a place where it's zero, just by nature of what's required in terms of having a tax that's across all plans.
Okay, and then maybe I can follow up with the plans with that question as well. Has the administration modeled a lower MCO amount other than the $1.2 billion at all? Has there been anything on the table?
We haven't modeled that. Obviously, we've shared how to model the tax, and certainly I think others may have done that, but we have not specifically looked at a lower amount. We've continued to try to target the 1.35.
Okay, and then again, following up what Senator Rabanta mentioned, and you'd mentioned about the excluding a couple of the few of the local plans. When would we know if the waiver, if the feds will approve that? Is that just a matter of putting it in front of them and then just asking for their permission?
That's correct.
It's not like you're going to ask and see if they would respond ahead of time?
Right. I mean, that's not typically the way that we approach CMS, because they do look for what is your state authority for requesting this waiver. And so it's actually a formal submission, much like, when we do state plan submissions or we do waiver submissions, it's actually a formal request for a review of our model and our proposal. And then they either grant or don't grant the waiver. We do this, as has been mentioned, for other provider fees. We get waivers, and they are similarly structured, where Medi-Cal is taxed differently than non-Medi-Cal, which is how we came up with the idea. And so, that will be something we'll do as soon as we have a legislative authority to do it. We will anxiously seek that and certainly try to work with CMS to get immediate response. It is one of the reasons why the timing is so critical. Given that we know that the tax is expiring in June, we need the time to have that conversation with CMS, get the submission to them, and find out what their response is. And hopefully it's the positive response we all want. But if it's not, we'll be in a bad situation. And if we don't have time to come up with something else, I think that would be unfortunate, and we would be losing the federal funds and the money that we've been talking about.
Okay, thank you. Is there any other questions?
One more, please. I'm
Sure.
sorry. As I'm sitting here listening and just, again, realizing how critical having a plan in place is. First of all, CMS does not turn on a dime. They are government, frankly, and I'm clear that takes a while. But I'm just thinking about the other programs that would be at risk. Coordinated Care Initiative. As I recall, the governor in budget last year suggested that if it wasn't cost effective, out the window. And so I just think it's important that we continue to be mindful, the collective we, of all the critical programs that would be at risk. Programs supporting children, DDS piece that we still haven't completely addressed, Coordinated Care Initiative, your proposal that we then finally went along with that is now at risk. What else, from your perspective or LAO, are critical programs? It's one thing when we talk about billions of dollars, but let's talk about specific programs so all of us are clear what's at risk. And I would put CCI in that category. Would you agree or no?
No, absolutely. I mean, I think, part of the challenge with CCI is the statutory provision about the poison pill that says it has to be cost effective. And so certainly the MCO tax has been a part of that calculation and has helped us meet that, and was one of the reasons why we increased the MCO tax several years ago to help with that. In terms of other programs, really any program could be at risk. I mean, I think that's where, if we're talking about having to find over $1 billion of savings in the program, that could be anything. It could be things that just came up, new benefits, new coverage options. I mean, it could be any of those things. And I think those are the choices we don't want to have to be in the position of having to consider, but those will be what will be on the table if we are faced with this big of a hole.
I just think it's important that that reality is forever in our face. Thank you.
Okay, I want to thank you. Perhaps maybe you can stay up here. We have one more presenter, so if we have any other questions, we can just go ahead and ask you. So we're going to move on to item number 4, industry update. Nick Luizos, Vice President of Legislative Affairs, California Association of Health Plans. Good morning and welcome.
Thank you, Mr. Chair. Mr. Chair and members. Again, I'm Nick Luizos, Vice President of Legislative Affairs on behalf of the California Association of Health Plans, or CAP. Thank you for inviting me to participate at this overview hearing. Being in the Ronald Reagan State Building reminds me of my second grade biography project where I portrayed the president in front of my class, complete with accent and cowboy hat. That was a long time ago. But in any case, thanks again for inviting us to participate. Because this is the first overview hearing of this particular conference committee, I'd like to briefly review some concepts we discussed earlier this year before I provide the committee with some updates on our more recent activities and thinking. By way of background, CAP represents 47 Knox-Keene licensed health plans under the Department of Managed Healthcare, delivering coverage to about 95% of the healthcare coverage market in the state. Nearly half of our plans participate in the Medi-Cal Managed Care Program, delivering services to about 13 million recipients. We continue to agree with the administration that finding a replacement for the existing MCO tax is important for the state of California. As you know, CAP was a strong supporter of the original MCO tax when it passed in 2009 to help save the Healthy Families program. Clearly, several things have changed since then, chiefly the issuance of guidance necessitating that the MCO tax be broadened to all health plans, not just Medi-Cal plans, as we've discussed. This means that an MCO tax would then ask employers, employees, and individuals to pay the cost or part of the cost of the tax. Today, only our Medi-Cal Managed Care plans pay that, so the existing tax is not an affordability issue in that sense. So I'd like to stress something that I stressed at earlier hearings, and we're not here because of anything the administration has done, the legislature has done, or the health plans have done wrong. We're here because the federal government for years matched our MCO tax with federal matching funds and in essence deemed that tax compliant, and now they've changed their mind. So we're all trying to untie this Gordian knot together, if you will, and it's very complex. So in response to the challenge, health plans decided early to work constructively with the administration and the legislature to find an alternative funding source, an alternative tax. We created a work group earlier this year and developed principles, namely that the tax directly benefit the Medi-Cal program, be equitable to the payers of the tax. In other words, no market dysfunction should be created as a part of the tax. It must also consider affordability to the purchasers of health coverage. Affordability is a very important consideration from our perspective because private purchasers of coverage are already paying higher taxes due to the imposition of the health insurance tax that was part of the Affordable Care Act. In addition, some employers and labor trusts are facing an excise tax that is commonly referred to as the Cadillac tax, which will initiate in 2018, and that was also enacted as a part of the ACA. So taxes and fees already represent a significant percentage of the premium dollar, and that's what we've believed that we should be thoughtful about adding any more to that tax load. With these issues in mind, our work group organized and spent the first part of 2015 analyzing the administration's January 2015 proposal, which we determined at that time did not meet our principles. Soon afterward, our trade association, working with the local health plans of California, LHPC, began an analysis of the federal Medicaid provider tax rules so we could identify some areas of flexibility and identify places that we could go with the tax. And soon after this work, we started modeling different ideas. In all, over 2015, we modeled 33 different versions of an MCO tax, and each time we ran into the same problems. A lot of those were kind of illuminated by the LAO's presentation on flat tax versus tiered tax. But in essence, one model would achieve affordability, one model would achieve equitability but was not affordable. Other tax constructs could be made slightly less expensive, but at the expense of fairness to the payers within the structure of that tax. And the constraints of federal guidance have not made our job any easier. They're very strict in certain circumstances, and it makes it very difficult to find a balanced solution. As we've discussed at previous hearings, the federal government is allowing states to keep their current MCO tax in place until the end of their legislative sessions. The current tax remains in place, generating revenue until July of 2016. Having said this, we know that the clock is ticking. An important development at the end of our legislative year was the release of a new MCO tax proposal by the administration that taxes Medi-Cal plans and commercial plans at different rates. It was a significant development for our perspective for a few reasons. It's, if you will, it's a bifurcated approach that treats different plans differently. This is an approach that we did not know was available to the state under federal guidance. It does, however, open up some possibilities to reduce the financial burden of the tax on the private markets. And at the end of session, the administration also, as Director Cantwell testified to, offered plans, breaks, or offsets on other taxes in an attempt to mitigate the impact on commercial payers. These offsets offered by the administration this summer combined with the new bifurcated model that taxes commercial and Medi-Cal plans differently, does indeed reduce the burden on employers and individuals purchasing coverage. And by using the split tax approach, for lack of another word, the administration's end of session model starts with the lowest overall impact on the private markets than we've seen. Therefore, in keeping with our principle of affordability, we focused a lot of our attention and analysis over the interim on this last proposal or latest proposal. So while that version is an improvement over previous models, it did not, of course, eliminate the financial burden on private payers. It would still tax commercial health plan customers by a hefty sum, approximately $115 million. Additionally, the tax and related offsets continue to be spread unequally. It's a tiered approach. Some of the offsets don't apply across the board in the same way for all of our members. Despite these questions, which we continue to analyze, our board of directors and our members have been very clear with us, and they've directed CAP to remain fully engaged in identifying a viable MCO tax formula that does not lead to higher premiums for consumers and, of course, meets our other underlying principles. We have been in contact with DHCS, including our director of Medi-Cal, with our questions about the model that they presented in order to get a better understanding of its various features. Our legal counsel has also been in contact with the state's actuary to discuss the bifurcated premise of the model and how it reacts with federal rules around tax equitability or uniformity. As a result, we have a better understanding of the state's logic about the permissibility of their latest tax model. Of course, it's not our place to ultimately judge that particular question, but the matter does raise the need to discuss protections for health plan consumers that would be affected by any new MCO tax. And we've spent a considerable amount of time over the interim thinking about what would be needed to ensure that adequate protections are in place to prevent the tax from affecting the coverage market beyond its intended purpose, a primary purpose of which, of course, is to draw down more federal money for the state of California. The idea of adequate protection for consumers is also important in the context of the recent LAO estimates, as we've talked about, that the state's economy is relatively strong and leading to better overall revenues for the state, even without a new MCO tax. So setting aside the discussion of any financial model, just for the moment, we believe the following protections must be included in any legislation authorizing a new MCO tax. And I'll acknowledge up front that some of these features are already in the bills that have been authored by the chairs, but some haven't. Number one, a 3-year sunset we believe is important. Sunsets have been included in all MCO bills to date and are important for accountability purposes, particularly if we're talking about a tax impacting private payers. Also, we believe that if the federal government objects or disapproves the tax, that the tax shall end. Again, this is something that we've argued for in previous trailer bill or other legislation related to the MCO tax. One thing that we could consider is whether the federal government must affirmatively approve the tax before it can be collected. We would like to see in any final deal, if we get there, language requiring reconciliation of the revenue. This is another important accountability feature that's been included in past bills, which requires the state to report to the legislature and to the payers of the tax about how the dollars are being used. From our perspective, generated revenue should be capped at a set amount for the full 3 years of the sunset. In our view, an MCO tax should solve for the $1.1 billion problem or hole in Medi-Cal left by the loss of the existing tax. A related feature should be that the money should be used for the Medi-Cal program. Any funding, moving on, any funding should also be used, from our perspective, to supplement, not supplant Medi-Cal services. This is something that we've argued for in every debate over the MCO taxes. Are we improving the program, or are we simply backfilling? And so, an improvement to the program would be the preferred result. And then we also do not believe that state departments or agencies should be able to raise a tax in future years without coming back to the legislature. There is a provision in the latest proposal that would require or allow the state to tinker with some of the parameters of the tax, which could lead to a tax increase, which wouldn't be directly stated in the legislation. So we think that's a problem and think that should be prevented. So in addition to financial models and other considerations, we think that these protections must be part of the overall discussion over an MCO tax. Again, California's health plans remain focused on how we can achieve our goals while minimizing any cost impacts on consumers buying health coverage. We feel that we need to build upon the progress initiated at the end of session over affordability and find a way, if possible, to offset further what we feel is a significant financial load a new MCO tax would place on consumers in the private markets. While this remains a remaining challenge, it's a worthwhile endeavor. We always want to encourage employers and individuals to buy coverage in the private markets as part of our commitment to healthcare reform in California. And keeping coverage affordable, we feel, is a key to continued success in that area. So thank you very much for inviting us to participate, and happy to answer any questions.
Thank you. Is there any questions from any of the members?
Thank you, Mr. Luisos, for your presentation, and I appreciate the different elements that you set forth that you indicated would be important components to any successful MCO tax. So I want to just ask Ms. Cantwell, are there any major objections to those? And I know it was a lot, but if anything jumps out at you as particularly problematic, I mean, my ultimate question is going to be what it was before, which was, I mean, are we close to consensus on this? If not, what are the challenges and how do we fix it? That's my ultimate question, but I want to start with the first question about the different conditions or requests.
Certainly. I think several of those have been, things that have been in prior MCO taxes. So I think, certainly looking at those and understanding the need for them. The one thing that just, and it's not only because it was the last one, but that did jump out at me, and I think linked to sort of also the federal government disapproving it and sort of that just being the end of it. I think, we've had in other provider taxes, for example, our hospital tax, some flexibility at the department to make tweaks and adjustments in order to ensure ongoing federal approval, instead of having to be in the situation we've been in for the last 9 months of sort of trying to get someplace and being at risk of losing money. And unfortunately, these kinds of things can't be retroactive. So I think we would be very concerned about anything that would really prevent us from being able to meet the July 1 start date. And I think some of those things about sort of things ending or not being able to make any adjustments would be of concern, which is why we included the language that we did in our proposal. And like I said, it's not unique to this. We do have some of that flexibility as well in other provider taxes. So that's the one that sort of most came to mind when I heard the list, but I might not have heard them all. So certainly that was the first time I heard the whole list. So if there are others, we can certainly follow up.
Would you like to make any comment, Mr. Luisos?
No, I mean we're happy to share. I mean, obviously, this is an issue that's still very important to us, and we will share that list with the state ASAP.
So I asked this question to Ms. Cantwell, and I think she appropriately said it might be better directed to you. Mm-hmm. Does the September proposal have a new traction that the January proposal didn't? And if it does, how close are we to getting to an ultimate deal? Mm-hmm. I don't want to seem impatient about it, and I'm not, but I am encouraged by some of the changes, and I just want to see if that's appropriately placed.
Yeah, thank you, Mr. Chair, for that question. Yeah, I mean, certainly the September proposal opened up new doors that we didn't know were available to us previously. And so the positive change there was the fact that it reduced the overall financial burden on private payers. And of course, we want to continue people to continue to buy coverage. It doesn't solve the problem all the way. We think that there's more work to be done in that area. It's a vexing question to try to answer. I think a lot of the offsets that were presented by the administration are helpful, but again, don't solve the problem. We still have equitability issues, not only with respect to the tiered structure, which is somewhat alleviated by the tax offsets, but the offsets in and of themselves are not equally applicable to our membership, creating different equitability-related questions in the tiered structure did at the beginning of the year. So trying to iron all of that out is very hard. We're taking a look at it. We know some of our plans individually are in conversation with the administration as well. I don't know what the content is of those discussions, but some of them have reported positive things. So it would be unfair for me to tell you that we're just right around the corner from this. But we do, feel that this is important and want to continue our discussions with the state, and that is the direction and charge from our membership.
Thank you.
So, go ahead, Senator Mitchell.
I was assuming you wanted to go last.
Yeah, go ahead.
Thank you. Couple points of clarification for me, Mr. Luizos, just so I understand your laundry list of what the industry is looking for. And so I'm not sure that I'm clear. You said that you all would hope for federal approval of the tax. Mm-hmm. Is that different from CMS approval in your mind?
That would be the same. I think that what's open to consideration here is whether it's upfront approval or if the feds disapprove the tax after it's submitted by the state. What is the applicability of the MCO tax on the health plans within the state of California?
So is your assumption that the department would administer it awaiting approval from CMS? Mm-hmm. Is that your concern?
It's been done that way in the past, and DHCS may have a better answer to this question. But in my previous experience on this issue, I don't know that the CMS has ever formally approved the tax. They just didn't disapprove it.
Got it.
I could be wrong about that, and I'll let Director Cantwell explain that better.
Okay.
Yeah.
So it is true for our prior MCO taxes because we did not consider them provider taxes.
But they were different.
Because they were different. Mm-hmm. So essentially, they approved them by approving the rates when we built the tax in. In this case, as we've talked about, because we would need to seek a waiver of provider tax regulations, this would be the first time we would actually have to request approval of the tax. Okay. So it is a different situation, and it would require us requesting and receiving official approval from CMS on the tax.
Got it. Again, you referenced you would hope that the funds would be used to improve program improvement. Tell me what you mean by that. How do you define program improvement? Would it include things like expansion or increase of provider rates?
Yeah,
the old AB 97 services that we no longer provide? I mean,
yeah,
how do you define program improvement?
Yeah, thank you, Senator. We haven't detailed a laundry list of what those improvements might look like specifically, but increase in rates to plans or providers so that we could pay for services at higher amounts would be something that could be a program improvement.
Okay, all right. The same question I asked the department in terms of have you connected with your national affinity group just to get a sense of, more brains at the table are better than fewer in terms of what some of your plans are doing in other states who are struggling with the same issue?
Yeah, we have been, our National Trade Association, the America's Health Insurance Plans, we've been in contact with them, but we've actually been in direct contact with my counterparts in the various states that are going through the same problem. We've talked to Michigan, Pennsylvania, Ohio. Oh gosh, I'm forgetting another state that's in the same situation. But we've had direct conversations with them, and we've shared some war stories about this. We're all going through the same thing. And it's been interesting to learn how those different states and their different markets are playing into this. So on some issues, we're able to compare notes, and it's been helpful. But the differences in the coverage markets in those states make it incomparable in some circumstances. So yes, we are discussing this.
But there's no apples to apples.
In some cases, yeah.
The page 15 of the LAO report has this chart, I think, that very succinctly reflects the challenge we're all experiencing. I have an extra one here if you don't have it. It's page 15. I can share. Okay, thank you.
Good at sharing.
Thank you.
And it's a chart of the trade-offs between tiered versus flat structure. And what strikes me is the first measure, more stable in terms of federal permissibility and revenue predictability. That seems like that should be the top of our goal list, and that's flat. And yet the second bullet addresses your industry, minimizes tax burden on total MCO industry, mid-size, and that's tier tax. And so, how do we get to a place where, granted, I agree with you, we don't want to, create an upside down effect for your industry, where the millions of Californians who are in local plans or in plans, private pay, are priced out of the market. And yet, we have to meet CMS expectations, and as policymakers, we want a revenue stream that's predictable. So, where are we? Is there a third option? What do we do? When you look at these two top priority kind of goals, and neither of these options really gets us there. Yeah. And this is really open to everyone on the panel.
Right, and so no, I appreciate that question, Senator. I mean, the issue with the tiered tax, if I can take that on directly, is, as you mentioned, I mean, it taxes different plans competing in the exact same market at different rates, and that is a problem. Even when you apply some of the tax incentives that the administration offered at the end of session, you're still hitting. It's a very price point sensitive market, and you're hitting price points that could lead to dysfunction in those particular markets, which is why a tiered approach is one that is very difficult for us to get behind. Having said that, the flat tax doesn't tax the Medi-Cal plans enough, if I could say that. That's the inherent problem with the flat tax. So, is there some sort of hybrid approach that we could look at? And so, the administration's model at the end of session was interesting in that it's a tiered approach, but it's a tiered approach that applies to commercial and Medi-Cal plans differently. So, assuming it's permissible, that is a model that we're currently analyzing as perhaps, as you said, a third option. We certainly haven't endorsed it yet, or and I'm not here to make any guarantees to that nature. But as I said, it does open the door to some interesting possibilities.
Do you think that there should be additional criteria on this cheat sheet? Does this kind of, at a 10,000-foot level, reflect?
I think if you're looking at it from
the real deal,
if you're looking at it from a pure policy perspective, from the perspective of policy decision makers, I think it's a good list. From the industry perspective, we have other criteria, which is we'd like it to go to Medi-Cal, for instance, and one of our principles is that it should be limited to the $1.1 billion hole that's left in the Medi-Cal budget.
And very quickly, final for me, this is really kind of a legislative rules process question, but a comment you made triggered it for me. We're not required, any extraordinary session doesn't have to adjourn, even though we adjourn sine die in the summer. The extraordinary session is sine die also? I mean, you see what I'm saying? It does not. It can continue on.
It is continuing right now until...
Well, I know now, but I mean sine die at the end of session in September.
It'll go on beyond that, I believe.
Okay. I see heads doing like this. But it triggered that question when you made the comment about, we've got to get it done by June, blah, blah, blah. And I just, because it's an extraordinary session, I didn't know if sine die adjournment was a hard stop on extraordinary sessions or not. I couldn't remember. Thank you.
And maybe we can get that information just to clarify for you. But Mr. Luizos, I want to, first of all, thank you for being here, but more importantly, thank you for your commitment to the plan's wanting ability to get an MCO tax passed. I also have written down what I believe are 5 concerns that you have, which is the 3-year sunset. We discussed the tax will end, how the dollars are used, program improvements, and I think I figured out what the 5th was. But if you could provide us in my office, because it's the first time I've heard some of the concerns that you've had to us as well, because obviously we're going to have to draft and amend if we agree, because it's going to be something that we're all going to have come to an agreement as well. And just kind of quickly following up on what Senator Mitchell mentioned with regard to comparing the flat to the tiered, and I would consider it and call it the newest modified tiered by the administration or by Ms. Cantwell. And my concern with the flat tax is the amount of revenue brought into the state is significantly less. And I think what we want to do is we want to maximize the amount of dollars we bring in to get those. And I know that the administration has been working very hard over the interim as well before the end of session with the gross premium tax and the bank and corp to offset. There was like $210 million in tax relief. And I know that there's different plans, but there is a willingness, at least from the administration, to kind of reach out to the plans to figure out how we're going to make this happen and resolve. And I am committed, I hope I speak for Assemblyman Rabanta, that we are committed to make sure that we do not leave a hole so that we could not be having to fill it in with this additional money that's coming in. That's money that's available that we're going to draw down. But now getting to the questions that I have for you is, what were some of the outstanding issues? Were there any outstanding issues that are still out there with some of your plans that maybe you might be able to discuss at this time?
Mm-hmm. Yes, thank you. Some of those are embodied within the what I'm calling the protections list of issues. I think the main overall concern, among others, is basically the issue of affordability. I think if we can drive down that private commercial plan impact even further to a negligible amount, then we'll be in a much better position in accepting of a proposal in this area. I think the affordability issues are our paramount concern. We don't want to tax individuals and families out of the market in their responsibility to buy coverage. I think that's the main one. I do know that some of my plans still have concerns with the tiered approach and how that affects them. And whether that's resolvable or not is something that we're taking a serious look at. And then it's really down to can we protect health plan consumers within the legislation? And we are concerned. I appreciate Director Cantwell's explanation of the issue, but we are concerned with the ability of the administration to quote unquote tinker with the tax while it's in effect, without any appropriate accountability measures.
Okay, and you had made a comment earlier, and I wrote this number down. I want you to clarify what this $150 million was. Is that for the additional cost that has to be passed on to consumer? And maybe that might answer the question that I asked Ms. Cantwell earlier. What are some of the anticipated costs? Is that one of the numbers you were referring to?
Yes.
Is that for the current form that we have right now, the current proposal that we have on the table?
So our read of the administration's last model, taking into consideration the tax incentives or offsets, was that it still left a burden, if you will, on the private markets of about $115 million, which is reduced from the previous proposal, but is still, from our perspective, very expensive. I mean, we're not in the luxurious position to say that a 1% or 2% increase in health plans' premium rates is a negligible amount, considering all the cost pressures in the healthcare system already. So we're very concerned about that, and so our focus is to see if we can come up with something that can drive that number down even further.
So that $115 million is even with the offsets that the administration is offering with the gross premium and the bank court tax as well?
Yeah.
And then is that going to be more on certain plans, and you don't have to call out any names of any particular plans at all?
Yeah.
Would it affect more them and more in the market than others?
It's a little bit hard to tell, and maybe the director has further information on this. One of the issues in analyzing this is that the franchise taxes, the bank and court tax, are not public. So although we have an aggregate amount of what that would look like, it's not possible to know what the impact is per plan. No, the gross premiums tax is a public number per plan, but the bank and corp's information is harder to get, if not impossible to get.
Yeah, I can speak to that. So just to confirm, yes, the $115 million is the net financial impact after accounting for the offsets, down from the 650 some odd million in January. And as I mentioned, in the aggregate, that's going to be 0.1% of revenue. It is different across plans. But the difference, sort of the spread of the difference, whereas in January, and these numbers I know better, it was somewhere between 0 and 4% of revenue. I believe every plan is less than 1% of revenue, with maybe one exception, but I'd have to confirm that. And so in structuring, even though we maintained the tiers, when you look at the details of the tiers, since we split the Medi-Cal and non-Medi-Cal business, the differential in the tiers on the non-Medi-Cal business is much smaller. Whereas I think before it went from, I'm coming off the top of my head, like 75 cents to $29 maybe in terms of per enrollee taxes. Now it's, I believe, 75 cents and $7. So the spread has come down, and that's minimized the sort of the marketplace distortions, as well as when you add in the impact of the offsets. And as was mentioned, part of the challenge, even for us, as the administration, is I also don't know which plans pay how much in the banking corp tax. So when we look at the impact, we're only able to estimate the net impact on an individual plan basis when you considering the gross premiums tax. The 90 million that we estimate in banking corp is just an aggregate number.
So here's kind of how I look at the $115 million offset, and I understand that's your concern, and I understand that you want to reduce it, which if we can, all the better. But the hat that I have to wear, that hat is a third of the population is on Medi-Cal. It's growing. We have fewer providers that are taking Medi-Cal. We have access problems. And when I look at $115 million in return for a $1.2 billion revenue infusion, with a lot of that coming from federal dollars, that's a pretty good return on our dollar. So that's why we're gonna need to push the plans to at least say, look, do we want to have this hole at the expense of this amount of money? So, I mean, I have to look out for the overall, for the entire population, the Medi-Cal population here in the state of California. So, I don't have any further questions. Are there any other questions that any of the members would like to close with? Or, okay, seeing none, I'd like to thank all of you for being up here this morning. I appreciate it. And we're now going to go to public comment. I think we have a microphone, or we can set up a microphone up here. So those who would like to do public comment, if we can come over to this side, we will have a microphone stand over here. If I can ask, and then maybe the sergeants, if we can also provide maybe a microphone to those who can't make it to this side of the room when it's appropriate. And then if you can please state your name and your comment. Please proceed.
Good morning.
Wait for him to turn it on.
Good morning. First and foremost, I want to thank you all for coming to Los Angeles and for holding this very important hearing. My name is Steve Miller. I've recently tried to retire from nearly 40 years serving people with developmental disabilities in every capacity, from personal assistant to CEO of nonprofit organizations. First, I want to say I think I'm slightly optimistic hearing from the various panelists that it looks like there may be a pathway to have this tax go forward. And I want to tell you how much I appreciate each of you recognizing that it's not dollars, it's dental services for poor children. It's health care for poor people. We need every dollar. But I also want to say that I can speak with conviction regarding the need for services for the developmental disability population. We're not looking at a governor who appears to be neutral and interested in factual information. The fact that the only criteria that people are looking at is the number of programs that have closed. Consider how desperate the agencies are that are looking at closure in the next 2 years. Think about staff that haven't had raises for 5 years that are leaving. I'm personally now still working as a volunteer for one family whose son is bouncing from skilled nursing facility to hospital to skilled nursing facility. All he needs is the kind of residential services that have existed until recently. We've looked in Senator Hernandez's district. We've looked in Senator Mitchell's district. There are no resources for the tens of thousands of people. We've got to get that 10%, whether it comes from the special session or whether you're willing to stand up to this governor and this administration and put it in the regular budget. It's irrelevant where those resources come from. Without them, many thousands of people's lives are at risk. You need to stand up to this administration this year, and I really appreciate very much your time.
Thank you. If we can provide a microphone for the next speakers, please.
Good morning, members of the committee, and thank you for this opportunity to address you. My name is Lilibeth Navarro, and I'm the Executive Director of CALIFE. It's an independent living center serving the central Los Angeles area. As you know, almost 40% of the disabled population in California reside in Southern California, and our area is one of the poorest, most diverse population. I would like for everybody to try to get together and make possible the drawdown of the federal dollars, so we cannot afford to lose 1.1 billion just because we're worried about the MCO tax and it's falling apart. Our consumers, independent living centers, are concerned about keeping disabled people living independently at home because it's the most cost-effective healthcare option. It's also very respectful of our civil rights. We do not want to be incarcerated in very expensive institutions. So with the onset of universal health care, we've had the CSI, and many people have opted not to go into HMOs because of the many unknown factors. Many of us have had 20-year relationships with our doctors, and we just lose them in one swoop. So we have special needs. Our people have special needs. We cannot afford to lose federal funding. We would like the restoration of the 7% of IHSS hours that were lost. They were taken from IHSS recipients that were trying to live independently at home. We need that restored. We have been denied the COLA for many years. Our people are living on $850 a month. Try to live on that. In the context of everyday living, rent alone can eat up 75% of that, if not all. So we see them every day coming to our centers, hungry, tired, First things first, please. Let's restore what's been taken from our disabled population, because we want them living independently so that they don't have to go to nursing homes. So also, we would like the money to go to the most people that have lost the most. We have enough bureaucracies. We have enough agencies. We need the money to go to the people that were taken from. And these are the people with IHSS and Medi-Cal. So please do everything that you can to draw down the federal funding, and let us not foolishly squander away that opportunity just because we have fallen on our face on how to use that MCO tax. We got to be wise, especially in these times. Thank you.
Thank you.
Good morning. My name is Cindy Soto, and I also work for CalLife. I work for Lilybeth. And I would like to first thank you so much for having your committee meeting here. We would really love it if you would have a committee meeting down here during budget time, because there's so many of us that cannot make it up to Sacramento. But anyway, I'm here to say that if the CMS, if the tax deal, falls through, do not make any cuts to IHSS. That's how I am not living in a nursing home, is because I receive IHSS. And when there was the 7% cut, 7% cut, oh, that doesn't sound so bad. Well, it is to someone who is completely paralyzed like me. I cannot move anything below my shoulders. And when I did have the 7% cut to the IHSS hours, I ended up in the hospital several times and with skin ulcers. And skin ulcers last for months, even years. I mean, it was a really devastating to me. So I'm really glad, that the hours came back, and I just hope that if you make any cuts, don't do it to IHSS. Thank you very much.
Thank you.
Hello, my name is Dina Garcia. I also work at CalLife. Thank you again for having a meeting down here so that we can attend. It's often difficult for us to have to fly to Sacramento to keep our voices known. I also, same thing, I'm asking you to please forget the federal increase the money that IHSS, and that's that. I'm a worker, I'm also a mom with a disability, and I believe IHSS, and if it wasn't for IHSS, I might end up in a nursing home, and then who would take care of my child? My child is only 10 years old, and he would teach exercise, and so do I. We had that kind of increase since 2009, and try living $800 a month, and raising a 10-year-old child. Any of us that are parents know that that's not humanly possible. So please think about when you're making your decision. Your voices of power. You change a lot every single decision that you make changes our lives. Please make the right decision and help us. Thank you. Okay. My name is Joy Guyona, and I'm an advocate for all different programs for the disabled. And I just want to say, I thank you guys for all your support, first of all, and thank you for being here. But I just want to really stress, like everybody else is stressing, we need our benefits as far as in-home support services and SSI, and also the developmentally disabled also needs their services as well. Okay, I was born with cerebral palsy. I can't physically do for myself every single day, just like millions of us. If I don't receive my benefits, then I'll end up in a nursing home, just like millions of us. So I really want to stress how important this is, because if a lot of us have to go in nursing homes or things like that, because either lack of care, financial reasons, workers can't get paid their wages so they can take care of us, agencies like the regional centers, supported living centers. If they don't get their funding, then the workers can not provide services for us as well, which will cause us also to live in institutions as well as with family members if we have any. And this is going to cost the state a lot more money. And we're going to be in more of a deficit, as you guys know. So please, please stress that. I really appreciate that. And also, I just want to say one more thing. I'm married to my husband, Rigoberto Gaiona, and he does not receive any benefits right now because he is not able, he does not qualify to receive them at this time. So we strictly rely on my income, which is SSI and Social Security. So it's very, very important. And he does receive a little tiny bit of income through the regional center, which helps us out a lot. And they also help us with his equipment and things like that because he does not qualify for Medi-Cal. Thank you for your time, and you guys have a wonderful day.
Thank you, and you have one as well.
Rigoberto Gana. Call me Rico. This is a Pathfinder communication aid. What happens? Hello everyone, my name is Rigoberto Gana. Call me Rico. This is a Pathfinder communication aid. What happens? Apartment expensive. I attended the self-advocacy class that Cal Life provided. Among the many skills I acquired, there's the one I value more is the ability to communicate effectively with our legislators and city officials concerning social service programs. Another aspect of THR program that I am familiar with and also learned more about was Access Transit. Access wanted to make a few changes. One was to close the reservation line from 10 p.m. to 7 p.m. Another change proposed was fare increases. We did give access to keep the reservation line open until 10 by going to the hearings and speaking about how these changes will not be good for anyone. We also advocated for Prop 30 to pass to help out with education and other social service programs. I expressed new ideas on how the state and local government can help to allow us to work like anyone else. One of the main reasons I would like to see this happen is so disabled individuals can buy a home.
Thank you very much. Appreciate it.
Good morning, everyone. My name is Desiree Boykin, and I work at the South Central Los Angeles Regional Center here in Los Angeles, California, on Southwestern Avenue. As a consumer advocate at SLARC, I love to advocate for my consumers. One of our major concerns is that they love their SLS workers to death. They will the SLS workers go hard. What I mean by go hard, they go from, it's not just from Monday through Friday, it's sometimes Saturday and Sundays as well, because they care about the consumers of SLARC. So I really would appreciate if you can consider the 10% for the SLS workers, because they really try their best. And I really, really appreciate everyone coming down here. Ms. Senator Mitchell, thank you again for coming down here. And everyone else as well. Everyone have a wonderful day. Bye-bye.
Hi, my name is Calvin Severa. It's an honor to be able to speak with you guys. I'm a newly handicapped. I'm with System Watch Advocate team. Thank you for the assistance, because without it, I'll be stuck at home. I'm looking into getting more services now, because I'm unable to take care of things, laundry, dishes, cooking, trash, things of that nature. And I want you to take a look at, you say the Handicap Society is a third of California. If you, every time you're taken away from that, you're putting a strain on the rest of the community as well. My son, he's helping me out now. My daughter, she helps me out now, but they can only help so much. And everything that you could do to help keep me with the dignity of taking care of myself, I really appreciate it. And thank you very much.
Thank you.
Hi, my name is Camille Jang, and I'm a Eastern Los Angeles Regional Center client. I'm on Jack, and also I used to be on straight Medi-Cal, but lucky I'm on Medi, but like for those who are on straight Medi-Cal, like you should fully fund it, because a lot of good doctors, especially specialists, don't take any Medi-Cal, straight Medi-Cal, and also like more funding for them to live in a safe community like South Pasadena, because it really helps your independence, because not in a bad area, but like in a safe suburb like Glendale or South Pasadena, if you can have like affordable housing in those areas where they're close to their families, where you can live by themselves but in a safe neighborhood. Thank you.
I'm Daniel Garcia. I have been here for many years advocating for the community. Many of you probably do not remember me, but I remember you, Mr. Hernandez. But while working for ECLA Regional and ECLA Independent Living Center. But the thing I want to tell you about this issue is I want to first of all, welcome you in a ironic way. Welcome you from today. LA, welcome you to LA in an unaffordable housing market. Unaffordable, inaccessible housing market. We are struggling here in LA, where the biggest county, in the biggest city, is here. And we pay our taxes here more than ever. And I want to say that my story is about everybody's story. That people with disability have been because the problem on ISS problem, we have poor quality services, very poor quality services. We want you to be aware that because we have this huge wide unaffordable housing, we have poor quality services, we have all these other issues that collapse. No one but the option to put that in a nursing home. No wonder why. It's the better option to put that in jail. And that's why I'm telling you, welcome to LA. LA is not affordable at all. So we want to know from all of you, please increase the affordable, please make LA affordable to all, not just to people who are depending on housing, but we want to make it accessible for all too. Okay, thank you very much.
Good morning. My name is Esther Kelsey, and I represent Westside Regional Center. I'm the chairperson of Consumer Advocacy, and I represent sub-advocacy groups. And one of our issues is the 10% as well. We would like to see the 10%. Because if we don't have it, we don't know. Some of us live on our own, some of us live at home, but we're concerned for those who's living at home, because if something ever happened to their parents, where would they go? And if we don't have, we're also concerned about the affordable housing as well, because it's extremely high, and there's no rent control. So that's my concern.
Good morning. My name is Linda Butler, and I'm a consumer advocate at the Westside Regional Center. And one of my concerns is supported living. I live with an aging parent, and I have staff that comes over 5 days a week, and they help me with grocery shopping and household chores and getting me on time to work. And I'm concerned because I need the supported living services just like other consumers. So I can get my errands done, so I can get to work on time. And I'm also concerned about affordable housing because it is extremely high. And I was wondering if you could please support the 10% budget. Thank you.
Thank you. Hi, my name is Janet Heinrichs Canterbury. I work at the Personal Assistance Services Council for in-home supportive services in LA County. And I really, really, really want to thank you for coming to LA to do this hearing. This is so wonderful to have the opportunity for so many people who can't get to Sacramento and do these important things. And this is a very important issue to us, and we've talked to some of you about this before, and I just can't tell you how wonderful it is that you're doing this. I am particularly moved by Senator Mitchell's comment about her alarm that she's feeling about the tax and whether or not we can get this figured out. I was reassured with Director Cantwell's response that she shares the alarm, and I want you to know that the Personal Assistance Services Council also shares that alarm, and anything we can do to facilitate conversations, to involve consumers in those conversations, please let us know. IHSS, as you know, I know I'm preaching to the choir, but IHSS is such a fundamental service, and to experience any more cutbacks in IHSS is just unconscionable. So I'm delighted that you're here, and thank you so much.
Good morning. My name is Melinda Sullivan. I'm the Executive Director of Lanterman Regional Center. We serve this general LA area, Glendale, Burbank, and Pasadena. And I almost didn't come to speak because we have so many self-advocates here that are doing the job and are doing a great job about it. But one of the things I wanted to emphasize is, again, I was glad to hear about the urgency. For me, it's beyond urgency. We have many service providers that are hanging on and that do not know how they're going to fill the budget gap if we can't address the service rate issue for service providers. If we can't meet that gap, it is going to impact the people that have already spoken here today. And I want to just remind us all that the DDS budget, I think it has something like 40% federal matching dollars, CMS monies. And so when we are not meeting our commitments to DDS and DDS perhaps to CMS, that is putting those monies at risk. And so we need to be looking at our programs. We need to be smart. We need to be working smart. But we need to look at it as a bigger picture and not just any one particular rate. And I will echo Mr. Miller's comment about perhaps what we need is some strong voices who will speak on behalf of the individuals we serve with our governor, who doesn't seem to have the same perspective as the individuals that are sitting here at the table today. Thank you.
Thank you very much for the opportunity. There we go. My name is Paul Van Doren. I'm the Executive Director of Community Access Center, the independent living center that covers Riverside County, providing services to people with disabilities, all ages, all types of disabilities. I'm also on the IHSS Advisory Committee in the County of Riverside, for the County of Riverside. And I certainly want to support the tax to continue to cover the IHSS program. It's the most important program for people with disabilities to live independently. But I also wanted to point out that independent living centers provide services to people with disabilities. It doesn't matter if you're on Medi-Cal or not on Medi-Cal. We assist those people, and maybe that's something to think about with the health plans. If 1/3 of the people are on Medi-Cal, 2/3 are not on Medi-Cal and in these health plans, but there is many services and agencies out there that can provide home and community-based services to people that could benefit those folks that are in these health plans and not in the Medi-Cal health plans. In Riverside County, there's 2 plans, IEHP and Molina. We work closely with them. That's the 2 plans that people that are on Medi-Cal belong to. Just real quickly, in the past 4 months, we probably have assisted 4 people to move out of nursing homes back into the community, which saves everybody money and improves their quality of life. 2 of those people were on Medi-Cal, but 2 of those people were not on Medi-Cal. They were in other health plans. And so I think the health plans need to look at maybe help support some of the community-based services that can benefit their members, whether they're on Medi-Cal or not. So we can definitely provide assistance to people that are in health plans that aren't Medi-Cal health plans. Thank you.
And real quickly, my name's Larry Grable. I'm the Executive Director of Service Center for Independent Life, which is in Claremont, serving the San Gabriel Valley. And I just want to echo what Paul says. We're both board members on CFILC, the statewide agency of the 28 independent living centers, and we stand by you guys and appreciate what you're doing. And number one, I want to thank you for extending the time for our comments today. We know we all have busy schedules and you have places to be. Senator Mitchell, I just wanted to thank you for one comment you made, and that's dedicated programs need dedicated funding, and that's why this is so important. Thank you very much.
Hello, this is Melanie Miles. I'm part of Avenue's supported living services. And without my staff, I wouldn't be able to go anywhere because I don't own a car. I used to drive, but I don't own a car. And my staff take me out and I go different places, interesting places. And it's Christmas time, and I've been helping people put up the Christmas trees and stuff. We got a real tree in our house. And I want to wish everybody Merry Christmas and a Happy New Year. I want to ask you, is there going to be new staff for Avenue's Supported Living Services? We need staff. So that's why I'm here, so I can express my opinions. Melanie Miles.
Hi, I'm Jill Martin. I'm also with Avenue Supported Living Services. I do direct support, so I'm with the people with developmental and intellectual disabilities every day. And I can see on that level how our lack of funding is affecting not only our agency, but services across the state. And it's really getting to be a desperate kind of situation, and it's affecting lives so directly. I just want to also remind you of the Lanterman Act. And as you can see, it would help all these wonderful people that have come today. We've gone to rallies, and we've phoned, and we've written letters, and I can't tell you how many hours we've put in because it's so crucial, and we've been passed over for so long now that we need you. We need you desperately, and we want to provide for the folks in this state. So please remember the Lanterman Act to help people to live in their communities independently, and we appreciate your help.
Hello, thank you so much for the opportunity to speak to you. My name is Paula Margison. I'm the director of the Independent Living Center in Orange County, and we do appreciate you coming to Southern California. I also serve on the State Advisory Committee for the Aging and Disability Resource Connection, which are called ADRCs. This is a new emerging innovative service delivery system that combines services to people with disabilities and people who are seniors that need long-term services and supports. And I really see the dilemma that you're facing in trying to resolve all of this, and I'm concerned about the inference today that I heard that the tax cost will be passed on to the consumers. I think that message came across kind of loud and clear. And we're interested in collaboration on all fronts and would like for you to maybe consider how ADRCs can serve a wide scope of the population, people with disabilities who of all ages, and with a focus on people who are aging and trying to age in place. And that is a system that's becoming very widely accepted in the United States, but California has no funding for that system. And I think collaboration, it pulls not only in independent living centers and area agencies on aging, but also many other collaborative centers that can lay the groundwork for a really well-supported long-term services and support system. So hopefully when this is all ironed out, there may be funding from this revenue stream to support that new system that will allow people with disabilities to age in place, and people who become disabled as part of the aging process to get the services they need. Thank you very much.
Good morning. Marie Torres from Ultimate Health Services, a federally qualified health center in LA and Orange counties. I want to thank all of you for being here today on this very important issue. As a community advocate, because I go back probably 40 years in the community, starting as a social worker, but now doing legislative advocacy, I strongly urge you to resolve this MCO tax issue to avert significant cuts that will impact the most vulnerable members of our community. You have heard from those most affected today, and we need to support them. We support the restoration of the IHSS cuts. Many of our vulnerable individuals cannot continue living in an independent community without that service. Also, as a healthcare provider, we cannot continue to sustain additional cuts, especially at a time when we are helping millions of patients gain access to vitally needed health care under the Affordable Care Act. I want to thank you for your deliberation and leadership today to help all Californians, and we look forward to a solution that will benefit all stakeholders. So I know this is not the end of a conversation. We are here to offer our services, resources, help facilitate conversations where, we ourselves also have contracts with health plans. We also are a health plan with the PACE program of all-inclusive care for the elderly. And we do not want to see cuts. We don't need that. We're still getting over AB 97 cuts. As many of you know, I've spoken to all of you here in the district or up in Sacramento. So anyway, just thank you again for holding this hearing in LA, for allowing so many people that, as they've said, they cannot get to Sacramento. And I look forward to continuing this dialogue with you.
Let me first of all thank the presenters who are here this morning, but more importantly, let me also thank all of those who came up in public comment, some very, very compelling statements. I think I have a clarification with regard to the special session. I was just notified that it will end by November 30th, and we'll have to shut down at that point to clarify one of Senator Holly Mitchell's questions. So with that, seeing no other comment, we are adjourned. Thank you.
Este es el Senado Estatal de California.
This is the California State Senate.